Hi, and welcome to our program, Complement Inhibition in Geographic Atrophy, Slowing Progression with Novel Treatments. My name is Steve Ferrucci. I'm the Chief of Optometry at the Sepulveda VA Medical Center in North Hills, California, which is one of the 3 VAs we have out here in Greater Los Angeles, as well as the professor at the Southern California College of Optometry in Fullerton, California. You see my disclosures here, and you can peruse them at your leisure. Also with me tonight, I'm excited to have Arshad Khanani, a retinal specialist. He's the managing partner and the director of clinical research and the director of fellowship at the Sierra Eye Associates. He's also a clinical associate professor at the University of Nevada, Reno School of Medicine in Reno, Nevada. So I'm happy to have him with us tonight. And here you can see his disclosures. So this activity is supported through an educational grant from Iveric Bio by MedEdicus. This is a COPE course, and it is accredited for continuing education for optometrists like myself. Here's our learning objectives that we're going to try to accomplish. After completing this activity, participants will be able to recognize epidemiologic indicators of patients who may be at higher risk for geographic atrophy, describe the pathophysiology of geographic atrophy as it relates to disease management, identify the features of geographic atrophy on imaging, review clinical trial data for therapy that targets complement for geographic atrophy, and incorporate education on geographic atrophy regularly into patient encounters. Here's the agenda. We'll start out with some welcome introductions, move on to epidemiology, imaging, then I'll present a case or two. Then Dr. Khanani will take over and he'll talk about pathophysiology, emerging treatments, and he'll present us a case. And then we'll wrap things up with some patient education, monitoring, and a conclusion. This activity may include discussion of unlabeled and/or investigational uses of drugs and devices. Please refer to the official prescribing information for each drug or device discussed in this activity for approved dosing, indications, and warning. So without further ado, we're going to get started with our program. So obviously, geographic atrophy is an advanced form of non-exudative AMD, that is dry AMD, marked by localized, sharply demarcated atrophy of the outer retina, RPE, and choriocapillaris. The lesions often begin extrafoveal, expanded over time to involve the fovea, and eventually produce central scotomas and significant VA loss. Geographic atrophy often affects both eyes, leading to substantial visual dysfunction. One thing to keep in mind, though, is even before the patients start to have actual vision loss, they very often will complain of visual issues such as scotomas in the peripheral vision or perhaps difficulty in dim illumination, which can be problematic even before you start to see a loss in their central acuity. Epidemiology, globally and as well as US prevalence, GA affects approximately 5 million people globally. In the United States, they think that it affects about 1 million people. GA constitutes 35% of all late-stage AMD cases. Many people feel these numbers are probably underreported because since there has not yet been any treatment until very recently for geographic atrophy, probably the numbers got underreported. So probably more people have geographic atrophy than we actually think. GA is age-related. Approximately 1 in 29 people age over 75 years, and 1 in 4 people age over 90 years are affected. So as patients get older, more likely to have geographic atrophy. And again, as the population in general ages, right, as people live longer and longer and longer, the amount of GA is only going to increase. It's certainly not going to decrease. Risk factors is many risk factors for GA, and a lot of them they share with regular dry macular degeneration as well. And these include older age, smoking, alcohol, obesity, systemic hypertension, cardiovascular disease, cataract surgery, and family history. And the genetic component of the disease is indicated by the influence of family history. So we'll talk about the genetics in just a little bit. So I mentioned the role of genetics in geographic atrophy. And when we start to think about the genetics, risk alleles such as complement factor H and ARMS2 significantly affect the development of macular degeneration as well as geographic atrophy. And the studies suggest that age-related macular degeneration risk is compounded for smokers with these genetic risk alleles. So in other words, if you have these high-risk genes and then you do behaviors such as smoking or UV exposures or other things, that's going to make you even more likely to get geographic atrophy. So these things work in combination. A lot of patients actually with geographic atrophy have significant visual loss as well as functional impairment. And, so we have to keep that in mind when we start to think about patients with geographic atrophy. Approximately 42% of patients with geographic atrophy are legally blind, and more than 1/3 of patients with geographic atrophy will experience greater than a 3-line vision loss within 2 years of the onset of the disease. But again, even those patients that don't have that 3-line vision loss, they still have other types of visual issues that are going to be concerning to them and may interfere with their daily life, even though their vision can be good. But again, we have to keep in mind that a lot of these patients eventually will lose vision from geographic atrophy if left on its own accord. This is one thing that sort of surprised me when I started to really learn a little bit more about geographic atrophy, become a little more interested in it, is the speed of the GA progression. And I think a lot of us might be under the assumption that the GA is a relatively slowly progressing disease. And if we have a patient with geographic atrophy, we have some time to kind of monitor it and some time before we act on it. But some of the newer studies are actually showing that it's a lot more quickly progressive than a lot of us might think. Certainly what I thought, to be honest with you. And in this particular study of over 1,900 patients with geographic atrophy, 66.7, so 2/3 became ineligible to drive within 2 years, and 16% became legally blind over a median of 6.2 years, neither of which is really that long if you think about it. And further, over 2 years, the worst seeing eyes lost an average of 6.1 letters, and the better seeing eyes lost an average of 12.4 letters. So again, this is not perhaps the slowly progressive disease that many of us might have thought. Any thoughts on anything we just talked about there, Arshad?
I think, Steve, thanks for having me here, and hello to everyone. And I think the topic is very relevant right now because, in the past, we really didn't care how fast the patients were growing in terms of GA lesion size because we didn't have a treatment. Now we have one treatment, another one coming that we'll talk later in this presentation. So I think it's very important to realize that GA actually grows much faster than you and I both thought. I mean, I think we kind of got into this mode of just kind of seeing these patients and not paying attention to the lesion size. But as you said, it grows pretty fast. And I think the learning for all of us from that is that we need to initiate treatment early so we can preserve vision, as you said. So I think that's the most important thing for me is, again, I thought that it grew much slower than what the data shows.
Yeah, 100%. Great. Fantastic. So I want to talk a little bit about imaging, and again, like you had mentioned, before we had any treatment for GA, it probably didn't really matter if we weren't looking for GA or if we missed GA, but now that we have treatments for GA, which we'll discuss in a little bit, it's really important to start looking for GA to try to find these lesions with GA and all that. So, imaging becomes really, really important, and finding GA becomes more important now than ever before, quite frankly. So really, there's a bunch of different ways to look for geographic atrophy. And, there's a bunch of different tools, and we'll go over some of them here. Color fundus photos. It's a good way. It's probably, I would argue, probably not the best way to look for geographic atrophy, but it's certainly a way. But certainly it's very ubiquitous. Most optometrists that I know have a retinal camera and have the capability to take color fundus photos. So it certainly is a way. I think there are better ways. Fundus autofluorescence, fundus autofluorescence is a way they use different wavelengths of light and different filters to look for lipofuscin, which is a byproduct of cell damage and cell death. And some of the geographic atrophy studies show us that FAF can really help us look for these GA lesions, and also to look for growing lesions and lesions that might have a tendency to progress. So certainly FAF is kind of a newer, maybe emerging technology. Many of the newer cameras now have FAF. So again, a nice way, in my mind, to look for geographic atrophy lesions. Fluorescein angiography certainly can be helpful as well. Most of us as optometrists don't have that capabilities in our practice, so that would be something that would be more, in the hands of a retinal specialist, but certainly it's helpful as well. And then on the bottom here, you can see, the OCT. And certainly OCT really, in my mind, is probably one of the mainstays to looking for geographic atrophy, as well as following for progression. In the middle, there's the B scan, and that's what we've all come to really become familiar with an OCT, the B scans. And what you want to look for with a B scan patient with a geographic atrophy is you can start to see loss of the retinal layers as well as the RPE. And then you'll get what we call transmission defects, because the light will transmit more in the area of geographic atrophy, because without the RPE, the light just penetrates further down. So you kind of see, and this isn't the best example. I think I'll show you one in a second. But you'll get a transmission defect that really can outline the geographic atrophy lesion. Then on the two sides, you see the en-face as well as the NIR image. And I think these are also nice ways to look at geographic atrophy lesions, and also to monitor them for time to see whether or not they're progressing and getting larger with time. So, I really think that the B scan, as well as the en-face image and the NIR on the OCT, are probably the best ways, in my mind, although color photos and FAF can also be very, very helpful as well. And this is what we kind of talk about with the hypertransmission defects. You find these patients, they get these hypertransmission defects, and with time, they'll grow and get a little bit more and worse, if you will, and that will just show us sort of the growing lesions here. But really, again, I think if you use any of these at your capability, or even best case scenario, all of them, right? The OCT, the fundus autofluorescence, fluorescein NIR, and color photos, those are really the best ways to look for geographic atrophy, as well as look to see if it's getting, whether it's getting worse over time. And certainly, drusen are a sort of a marker and a progression biomarker for geographic atrophy. The more drusen you get and the larger drusen and all that sort of thing, it's going to help you predict the patients who's going to have worsening geographic atrophy as well. The other important thing to keep in mind, and we touched on it earlier, is GA growth. And one thing we know, again, from studies is that the lesions do grow with time. They grow in size, they grow in number, they grow in shape, and the location as well, as it expands toward the fovea. And we know also from studies that the progression rate varies according to lesion size. In general, larger lesions, sometimes progress a little bit more quickly than smaller lesions in general. But the thing we know is that the lesions do ultimately progress over time. So they've looked at certain factors of lesions that can help predict how quickly they might grow over time. And what we found that some characteristics are associated with increased growth rate, and some are associated with slower growth rate. So as an example, multifocal. So that when you tend to get multifocal, more than one lesion, sort of little islands of lesion, those tend to grow more quickly than just one large lesion. Also, to progress into other configurations, rather than staying in the same shape, those also tend to grow faster. Irregular lesions grow faster than very circular type lesions. Lesions that are extrafoveal tend to grow faster than the foveal lesions. And then larger lesions at baseline also grow more quickly than smaller lesions at baseline. So you can kind of use this to kind of look at a lesion and kind of, think about, is this a lesion that's likely to progress with time, or is this one that perhaps might remain more stable with time? There's these things called outer retinal tubulations, ORTs, and these are arrangements of damaged photoreceptors, and it's associated with rapidly progressing geographic atrophy. And unlike cystoid macular edema, it has a distinctive reflective border and is in the outer retina, so it looks different than cystoid macular edema. And what they found in studies, it's present in 65% of eyes in the atrophic region and 26% of eyes in the junctional zone. And patients that have these outer retinal tubulation, it seems to be a prognostic factor for patients that have more rapidly progressing GA. So if you see these ORTs, you're going to want to perhaps see these patients a little more frequently in order to look for them. So I know as a quick but hopefully thorough discussion about imaging, do you have anything you'd like to add there, Arshad?
Steve, that was a great overview. I think, as you mentioned, the main thing is to use multimodal imaging to follow these patients. As you said, color photos are helpful. If you don't have FAF, you don't have IR, I think color photos kind of give you an idea of the lesion size. Sometimes you can miss GA on color photos, but as you said, most of the time they're helpful. So if you just have color photos, you don't have FAF, then I think I would follow every 6 months or every year, wherever you follow your patients with, do take color photos. I think OCT is gold standard. Steve, as you said, I think, you're able to see hypertransmission. You're also able to see, photoreceptors and ellipsoid zone. And the reason for that is you may see on FAF that everything is dark in the center. You have a patient that still sees 20/30. And the reason is that they have some photoreceptors left subfoveally. So you're right. Start with OCT, and then whatever other modality you have, try to utilize it so you can follow the growth of GA lesion. I think that's going to be important with treatments. We know that everybody's going to grow. It's a disease that grows in all patients. And as Steve said, there are certain characteristics of patients that make it grow faster than others. But you will notice even with treatment, every patient will grow, and we'll review some of that data later in this presentation.
Fantastic. So I just want to show a couple couple cases that I've seen over the last couple months or so, and we can talk about those cases. So this is my first case, 89-year-old male, known to the clinic. We've been following him for multiple years. History of dry macular degeneration. He's on AREDS2 BID. I'm a big proponent of vitamin supplementation in the appropriate patients. Previous smoker, but he's discontinued, but he has 20+ pack years worth of smoking history. He reports gradually decreasing vision, both eyes, as well as difficulty reading as well. And he does note some difficulty in dim to well-lit illumination and vice versa. So here he is. His vision's relatively good. It's 20/25 and 20/30. But here on the color photos, I think we can appreciate some geographic atrophy lesions in both of his macula. If we look in the next picture here, here's the OCT here, and this is in 2023. And again, the vision's 20/25 and 20/30. But I'm not sure you can see my pointer or not, but you can kind of see that transmission defect there where the light goes more through, it penetrates more in the area because you have that loss of the retinal layers and the RPE. So you can kind of see that transmission defects that's very characteristic for geographic atrophy. I've also heard it called a waterfall defect. Some people call it a barcode defect. So there's a little bit of different terminology in the literature. It seems like people have sort of settled on hypertransmission. So that's what we're hearing more and more these days, but you can see it in that patient. I looked back at the patient, that was in 2023, just a couple months ago, to be honest with you, maybe about a month ago. So I look back at what he looked like in 2020, and in 2020 here, we don't really see that geographic atrophy, but we can just see some drusen in this patient's eye. And, 3 years ago, he just sort of had some drusen. We can see the drusen there, but not really too much GA. So he's really developed that GA within the last, 2-3 years with time. And even though his vision is about the same, 2025, I think it dipped to 2030 now, because of the GA, he's having more difficulty with his vision and visual functioning, even though technically the vision didn't get any worse. So this is a patient with bilateral geographic atrophy. We've told him to continue the vitamins. We also talked to him about, other lifestyle things, no smoking, eating healthy, UV protection, and that type of thing. We told the patient to come back in 4 to 6 months to look at him again. In retrospect, I might have said, maybe even a little bit sooner, maybe, 3 months or so. And this is a patient that certainly we're going to monitor the patient for a little while, not going to keep him hanging for too long, but I might see him back in 3 months. And if it looks like he has any, any progression at all, we're going to certainly think about sending him for some potential treatment for geographic atrophy. I'll present my other case, and then I'll kick it over to Arshad if he wants to add anything. Here's another case. This is an 85-year-old male. I just saw him within the last couple of weeks, and we've been seeing him for a couple of years. We knew he had geographic atrophy. We've been following him every, about once or twice, about every 6 months, about twice a year, also on AREDs. He came in and he thought he was doing relatively well. He said the vision was about the same. He reported that he had pegcetacoplan injection in his left eye about 10 days ago, outside of the VA at a private institution, and he was going to go back in about 2 weeks to have his right eye injected. And it was exciting to me because this was actually the first patient that I encountered that had received these treatments that Arshad's going to talk about a little bit later. So here he is. He's 20/50 each eye. Here's the color photos. And again, I think you can really nicely appreciate the GA in both eyes. And, his right eye, he's sort of got two discrete areas. And then in his left eye, he's just kind of got that one very, very large area. And he's about 20/50 in each eye. Here's the red-free photos. I always like to take red-free photos. Sometimes things just look slightly different on red-free. And if you're taking color photo, it's very easy. Just hit the little button, take a red-free photo. So I like to do that whenever I can. Here's his OCT. Here, in the NIR, you can really see the lesion in the eyes here, the right and left eye. And here you can really appreciate that waterfall defect, the transmission defect that we were talking about earlier, the hypertransmission. So you can really see that there, I think, in both eyes. Here he was back in 2020. So I went back and I looked at him in 2020. His vision was about the same. He went from 20/40 to 20/50. So it did decrease a line over the last couple of years. But here, I think we can still appreciate the geographic atrophy, but it's not quite as advanced. On the top here, I'm showing you 2023. On the bottom is 2020. And I think you can appreciate that it has, in fact, increased over the last several years. Here it is again. I'll be honest with you, just for this, I measured it. Most OCTs, you have calipers, you can measure this type of thing. So I measured it. You can see that it's actually, increased over time. Honestly, I don't always measure them. I was just doing it to, kind of prove a point, but you certainly can measure them if you're interested. And in this left eye that has this singular lesion, you can see, I think, even a more progression in this eye. It's progressed from, a little over 5 millimeters squared in 2020 to 7.7 millimeters squared in 2023. So it can just, help you see how fast these things are progressing. So this patient has progressing geographic atrophy. We suggested he continue with his injections as scheduled. We told him to continue his AREDS2. We'll talk about AREDS2 a little bit later. Also, again, talked to him about his lifestyle discussion, no smoking, healthy diet, UV protection, stuff like that. And we're going to see him back in about 4 months or so to see how he's doing. Do you have any thoughts on those at all, Arshad, before we move into our next section?
No, Steve, those are great cases, right? They just highlight a simple fact that it's a progressive disease that will eventually take away the vision of the patient. And I think that's the bottom line, is that the tissue loss is vision loss eventually. Some of these patients may have 20/20 vision and can not have too many symptoms, while others will have a lot more symptoms. So I think it's important for the optometrist to actually look for GA in their patients, because now we have a treatment. Even if they're 20/20, they can have non-foveal GA, and that can still give them symptoms, and we know that's going to grow over time. So bottom line is that the disease is going to grow in all patients, and early diagnosis, intervention, and treatment is the way to go.
Yeah, 100%. Couldn't agree with you more. So with that, I'm going to kick it over to you to talk to us a little bit about pathophysiology.
Absolutely, Steve. Thanks for giving an excellent overview of the disease itself, imaging, and sharing with us some cases. So my goal now is let's dive a little bit into the pathophysiology of the disease so we can talk about what treatments we can use to slow down the disease. So when you look at GA, as Steve mentioned, it's basically atrophy of the outer retinal tissue, RPE, and choriocapillaris. And the idea is that there are multiple factors that lead to progression of GA. As discussed, number one is aging. So if you've seen the data, as you get older, every decade, there is an exponential increase in incidence of GA. Number two is genetics, obviously complement gene and haplotypes, and those are obviously risk factors. And then the society, in terms of social issues, smoking, obesity, or diet, they play a role. And then the last one is inflammation inside the retina. And I think that's where the complement pathway comes in, where it leads to inflammation, leads to formation of membrane attack complex, leads to the cell death of photoreceptors and RPE cells. And the idea is that, can we stop or shut down the complement system, which leads to cell death? And if that happens, we are able to slow down the loss of tissue or progression of geographic atrophy. The complement system is nature's way to fight infection. It has multiple different parts. It has the lectin, the alternative and classical pathways. I don't think we need to go too much into it, but I think the bottom line is that they all come together, and you have multiple steps in the complement pathway, which you can inhibit. And at the end of the complement pathway, we have the membrane attack complex, which leads to cell death. So the idea is that, can we inhibit this pathway to stop the progression or slow down the progression of the disease? So we have two ways to do this. The field has been looking at multiple different ways to do it at different points, different modalities, injections, gene therapy, pills, subcutaneous injections. So there are different ways, but I think the two programs that I want to talk about today is obviously the most advanced one. So the first one is pegcetacoplan, which was recently approved by FDA. And what pegcetacoplan does is that it blocks C3. So the idea is that you block the complement pathway at C3, or the next one is avacincaptad-pegol, which blocks C5, which is more downstream. So I think those are the two treatments we'll be talking about. You don't need to, again, dive into too much detail, but if you remember that pegcetacoplan works at C3, avacincaptad-pegol works more downstream with C5. So what are the other things that lead to complement hyperactivity? And we know that complement factor H, and there have been numerous studies showing that complement factor H deficiency leads to overactivation of the complement cascade via the alternate pathway. And this is another target that is being looked at in clinical trials, either by supplementing complement factor H or using gene therapy to produce complement factor H. But again, outside the scope of this disease. And we know that the risk alleles of CFH arms 2 are associated with complement activation in patients with dry AMD. So pegcetacoplan and avacincaptad pegol are the two medicines we'll be talking about today. So pegcetacoplan was approved earlier this year, and avacincaptad pegol is approved by FDA August of this year. So what is pegcetacoplan? It's a cyclic peptide inhibitor of C3. As I mentioned earlier, it blocks the complement system at C3, and it is administered via intravitreal injection every month or every other month. And obviously, we're going to look at that data. Just again, a reminder, avacincaptad pegol is more downstream, and it blocks C5. Derby and Oaks were phase 3 trials that were initiated to look at benefit of pegcetacoplan. This was based on the Philly study, the phase 2, which met the primary endpoint. Derby and Oaks are randomized, double-masked global studies, and each of them included a large number of patients. And the idea was FDA allowed the endpoint, not of visual acuity, but rather the growth of GA lesions based on fundus autofluorescence. As you saw, Steve showed you the pictures where you have those dark circles. So the idea was, compared to sham, can we slow down the progression of GA? So patients either received monthly or every other month pegcetacoplan, and this was compared to monthly or every other month sham. And the hope was that patients in sham group are going to grow faster than patients in the treated group, highlighting that this treatment is slowing down the progression of geographic atrophy. So here is the 24-month data. Both studies were 24 months, and then the extension GALE study is still ongoing. At 12 months, the primary endpoint was met in the Oaks trial, but it was not met in the Derby study. So the studies didn't meet the primary endpoint in both, but just in Oaks, not in Derby. But when you look at the 24-month effect, you saw that continuous effect and separation of sham versus treated group. So the lines on top are the sham group, where you see the progression of GA, and the bottom lines are the treated group every month or every other month. And you can see that there is a clear benefit. So at the end of 24 months, there was a 19% reduction in GA growth in patients in Derby treated with pegcetacoplan monthly versus a 16% reduction with every other month. And both p-values were nominal, but they were significant compared to sham. When you look at Oaks, the effect was more in Oaks. It was 22% reduction in GA growth at 2 years compared in monthly, compared to 18% in every other month. And this is obviously compared to sham. So based on the 24-month data, FDA approved pegcetacoplan for patients with GA, and we're going to be collecting more data. GALE data early cut will be presented this year. So GALE will be a 3-year extension study. So the hope is that the curves will continue to separate. So the idea is that the sooner you treat the GA, the more benefit you get over time and more preservation you will get. Given this, we have not seen a functional benefit in terms of visual acuity at 24 months. There was no difference in treated versus untreated group in Derby and Oaks. Now, let's look at the benefit. As I was discussing, the benefit increases over time. So if you look at the benefit between 0 to 6 months and compared to 18 to 24 months, you can see that over time, the benefit increases. So again, it shows that we need to inhibit the complement pathway, and with continuous inhibition, you are able to slow down GA. Now, obviously, you notice that this does not stop GA. It does not reverse GA. So when patients you see are on treatment, they are still going to get worse. And that's something we notice in the trials where patients are saying that my vision is getting worse and I'm in a trial, I must be on sham. Well, I was masked, so I didn't know. But the answer is that they would get more progression if they were untreated. So there's no biomarker for us to see how good the treatment effect is in the real world once we are starting to treat. So it's essentially a lifetime of treatment. And I think patients need to know that upfront, because we're not comparing it to anything, right? Here we were comparing it to sham, so we had the data, but each patient will have a different benefit, but all of them will have continuous growth, but we're slowing it down. So setting patient expectation is an important part of GA treatment, and the optometrists are actually very closely involved with this. So you have a patient coming in asking you, well, I'm getting treatment and getting worse. The answer is, well, if you were not getting the treatment, you would get worse even faster.
Looking at safety of pegcetacoplan, there was a 0.034% per injection rate of infectious endophthalmitis, 0.24% per injection rate of intraocular inflammation. Looking at the real-world usage, most clinicians opt to every other month injections to minimize the following adverse events. Neo-onset exudations at 24 months were 11.9% with monthly injections, while 6.7% with every other month injections. I think the most important one related to dosing is ischemic optic neuropathy. In the every month dosing, the risk was 1.7%, and in every other month, it was 0.2%. Looking at the usage of pegcetacoplan since the availability and FDA approval, in the real world, 8 cases of retinal vasculitis events have been reported between April 18th to July 21st of this year. 7 of these cases were occlusive per ASRS REST committee, and this is with an estimated 65,000 vials distributed at that time.
Next few minutes, let's go to avacincaptad pegol. As I said, it's a potent inhibitor of C5. It's more downstream. And this was studied in both 2 pivotal trials, GATHER1 and GATHER2. GATHER1 and GATHER2 programs, both trials met the pre-specified primary endpoint. So avacincaptad pegol is the first drug to achieve that. As a reminder, I told you that Derby study with pegcetacoplan didn't meet the primary endpoint at 12 months. And again, in both trials, we saw decreased growth of GA compared to sham. Here's 18-month data also showing the continuous progression of treatment effect, so lower progression in the treated group. So again, early treatment effect in both GATHER1 and GATHER2, and continuous treatment effect over time in both GATHER1 and GATHER2, confirming the efficacy of avacincaptad pegol. In terms of safety, there were no cases of endophthalmitis in either trials. Obviously, most of the adverse events are injection-related. When you look at exudation, the exudation rate in GATHER1 was 9%, and in GATHER2 was 6.7%. So we did see a higher rate of CNV. In treated group, again, confirming that inhibition of complement pathway actually leads to increased risk of CNV, which I tell all my patients. Now, one thing to keep in mind, there was very good safety in terms of intraocular inflammation. There was only one case that resolved over time in both programs combined, and there's no events of ischemic optic neuropathy at 12 months in both of these trials. So it appears that there's a better safety profile with monthly avacincaptad pegol compared to pegcetacoplan. Obviously, we are awaiting the 24-month data and then, of course, the extension data. One thing I want to cover before we finish this part of the program is the fact that the recent analysis showed that patients in GATHER1 and GATHER2 received treatment. There was a 56% risk reduction in persistent vision loss, which was defined as 3 lines of vision loss over 2 consecutive visits associated with GA. So there is actually a benefit in terms of slowing down vision loss. And also the fact that patients who lost vision with sham or avacincaptad pegol, the growth rate were lower with avacincaptad pegol compared to sham. So really, this is the first time we have seen functional and structural relationship where treatment with avacincaptad pegol slowed down or lowered the risk of 3 lines of vision loss at 1 year by 56%, and also slowed down the lesions overall. So the bottom line is, when I talk to a patient, once avacincaptad is available, we'll be able to say that if you could get treatment, there's a 56% reduction in 3 lines of vision loss, which may mean that you may still be driving, which may be beneficial in terms of convincing a patient for treatment. Steve, any thoughts on the data?
No, other than it's absolutely fascinating. Every time I hear you talk about it, I learn something else. So, it's very, very, encouraging because, if we can slow down these lesions, and let the patients live more independently for a longer period of time, that's really the goal, right? So it's very exciting, I think.
Thank you, Steve. Yeah, I mean, I think the paradigm is shifting, right? We are used to great anti-VEGF results where patients stabilize or improve vision. Here, the paradigm is like, if you remember, like PDT, where you're slowing down the vision loss in these patients. So I think that's the discussion that is taking a lot of time from treating physician ends, that we have to set the expectations up front, that you will progress. We're just slowing down the progression. You will lose vision, but we're slowing down the vision loss. And I think that's where the optometrists and ophthalmologists and retina specialists need to work together, diagnosing these patients early, treating these patients early, and setting expectations correctly. So over the next few minutes, Steve, I would like to share one of my cases, 85-year-old female presented with decreased vision, both eyes, non-smoker, long-term usage of AREDS 2. This is from September 2017. You can see the OCT where we have visual acuity, pinhole 2050, 2060. And as Steve mentioned, you have some hypertransmission defect in the right eye, not much in the left eye. So more advanced AMD in the right eye compared to the left eye. And when you go to the next slide here, you can see that there is 2050, 2150 here, and you can actually see hypertransmission centrally. So this is one thing about this disease, is that not only it's a disease that will progress in 100% of the patients, but also a disease that's unpredictable, right, Steve? Like here, we didn't see much of the GA around the fovea, but the first lesion shows up in the fovea, and you have vision loss associated with it, right? You have seen those cases before?
Yeah, I mean, sometimes, it's not sometimes it's not how much you have, but where it is, right? And unfortunately, this patient's left eye, it just smack dab hit right in the wrong spot, right?
Yeah, so unpredictable disease. That's why it's super important to initiate treatment early, because you may have a lesion away from the fovea and the next one shows up on the fovea. And in this case, the eye with less GA lost vision because, as you said, it's the location. And these are fundus autofluorescence pictures. So you can actually see there's a lot more GA lesion in the right eye, but the visual acuity is good because the fovea is spared. And here you have very few lesions, but the visual acuity is down in the left eye, again, highlighting that we need to identify and treat these patients early. And then this is further follow-up. You can see visual acuity continues to get worse in the left eye because the lesion continues to enlarge. And this is the FAF of it. And then 2 years later, count fingers with a very large lesion in the left eye, while the right eye, the bad eye, is still holding up a little bit because we still have some photoreceptors foveally. And then here's the FAF of it. Again, highlighting this is a progressive, unpredictable disease that will blind the patients eventually. And, Steve, I'm sure you have many patients that you're seeing for last decades or 15 years that were 20/20, and now they're hand motion, count fingers or hand motions because the GA just took over both eyes, right?
Yeah, very, very, and it's very, very frustrating because, we could do nothing, right? I mean, they didn't have any wet disease. There was no treatment until now. So, I just wonder how that patient would have done if that was today rather than, 5 years ago when you first started seeing the patient.
Exactly. And I think that's the whole point, is identify early where the optometrist will play a role. I really agree with you, Steve, and you said it's underdiagnosed because people are not looking for it. And actually, many patients with non-foveal GA are with the optometrist as primary care eye providers. So I think it's an opportunity here to find these patients, diagnose. And I'm not saying that I'm treating everybody, right? So if somebody already had too much damage and our count finger, may not be worth treating them because the fovea is already involved. So the earlier treatment you have, the better it is. So Steve, I'll pass back to you to talk about patient education and monitoring.
Great. Thanks so much. But, besides pharmacological treatment, which Arshad talked about beautifully. There's other things you can recommend for your patients with AMD as well as geographic atrophy. Certainly, smoking cessation is important. Smoking has been found in multiple studies to be the #1 modifiable risk factor for getting AMD as well as its progression. So important to talk to our patients about quit smoking. Low vision rehabilitation, I personally don't do low vision, but it can be very, very helpful for those patients because, again, even in the best case circumstance, we can slow down their disease, but they still may lose vision. So they still are going to have reduced vision, and low vision can go a long way. Mediterranean diet, a lot of newer studies have shown that patients who adopt a Mediterranean diet, that's one that has a lot of plant food, fish and olive oils, limited red meat and saturated fats. They do better when it comes to the AMD progression. Supplements, I mentioned earlier, I'm a big supplement person. I think the AREDS too is a good thing to do in our patients with zinc and antioxidants in our appropriate patients with geographic atrophy. Sunglasses, reducing sun exposure. We know that's bad for AMD. Exercise, healthy BMI. I read one study that said, being overweight is probably the second biggest modifiable risk factor, second only to smoking. So that's important as well. And certainly AMSL grid. And then now there's some newer ways we can also monitor patients for metamorphopsia as well are important. If the patients notice a change in the AMSL or increased metamorphopsia, that's an indication that things may be changing. Their AMD may be getting worse, and they need to come in and see their optometrist or their retinal specialist to get that evaluated. I mentioned low vision again can really be beneficial in those patients, whether it's helping out with the mobility, reading, driving, helping out with their quality of life and that sort of thing. And really, just like treatment, you don't want to wait too long. It's the same thing with low vision, right? It's better to get them over to the low vision specialist earlier rather than later. When they have more vision, they have more options to do things. So certainly think about that. And there are notable organizations such as American Foundation for the Blind, National Federation of Blind, and Lighthouse Guild. And again, as an optometrist, I know not all of us, are comfortable doing low vision or have that in our toolbox. But if it's not something you do, send them to your optometric colleague that does low vision, because it really can make a big difference for these patients for sure. We talked about supplements, ARED supplements, and AREDs have really been shown, especially the AREDS 2, has really been shown to be helpful for patients with AMD, decreasing the progression of their disease in patients with intermediate or worse macular degeneration. The studies aren't really as clear for patients with geographic atrophy, whether or not vitamins are super useful for patients with geographic atrophy versus, drusen type macular degeneration. But, to be honest with you, I still recommend it because, even if it helps a little bit, a little is better than nothing. So even though the studies tell us it might not be as helpful for geographic atrophy, I still think it's a reasonable thing to do in our patients. And I still do talk to them about using vitamin supplementation as well as those other things we talked about: healthy diet, no smoking, UV protection, and things like that. You certainly want to see these patients, routinely based on the level of their disease, their acuity, their history, and other things as well. Again, you are going to want to send a patient over to the retinal specialist, especially if they have geographic atrophy, especially if they have bilateral geographic atrophy, especially if you see that geographic atrophy is getting worse over time, right? If you follow that patient for a couple of years and you see it progressing, that's a perfect patient to send over to your retinal specialist. And the way that I approach it to patients, I tell them, hey, we're fortunate we have a new treatment. It's only been out for a couple of months that has been shown in studies to slow down the progression of geographic atrophy. Again, like Arshad said, it doesn't reverse the damage already done, but hopefully it can prevent more damage moving forward, or at least slow down the damage moving forward. So I'm going to refer you over to my colleague, my retinal specialist colleague, and see if you'd be a good candidate for this exciting new treatment. So I like to plant the seed in the patient a little bit to tell them, why I'm doing this, why I want them to see this doctor. And then ultimately he's going to make the decision whether or not this treatment is right for that patient. And, as optometrists, when we send the patient over to the retinal specialist, this is a patient that we might have been following for years. So I think giving a brief history of what we're seeing over time and how we might have seen it progressing, whether lesion size or decreasing vision or increasing symptomatology, might really be helpful to give to the retinal specialist who might be meeting the patient for the first time. So that's kind of how I like to, approach it when I'm sending a patient over. Any thoughts on that, Arshad? How do you think that's useful information for us to give to a patient when we want to send them over to you for potential treatment?
Absolutely. I think you have been seeing the patient for a long time and you have good rapport with the patient and they trust you. So yeah, you need to say, now we have a treatment we were watching before. Let's send you to the retinal specialist, and then he can or she can discuss risk benefit with you, and then we can go for the treatment. So I agree with you.
Fantastic. So, in conclusion, I just want to kind of reiterate a few of the key points that I hope you take home from our presentation tonight. Geographic atrophy, it's pretty common and probably even more common than we think. It impacts about 1 million US citizens, accounting for 35% of advanced AMD, with 1/3 losing significant vision loss within 2 years. And again, I think that number 1 million is probably a little underreported. Geographic atrophy greatly affects the quality of life, including functional, emotional, social, and financial aspects of patients who lose vision from geographic atrophy. Diagnosis is multimodal, uses fundus imaging for initial and progressive monitoring, but really the OCT is really showing us to be the gold standard way to look for these lesions. Inflammation via the complement cascade activation is pivotal in GI pathophysiology, as well as the new emerging treatments. And current and upcoming treatments slow geographic atrophy progression, but do not stop or reverse it. Nonetheless, they can really be beneficial for our patients with geographic atrophy, because by slowing these lesions' growth, it can really help them be more independent for longer. And patient care includes diagnosis and treatment education, monitoring, and referrals. And I would just say that now there's a treatment for geographic atrophy. It's really important as optometrists that we look for these patients with geographic atrophy. We identify these patients and refer them over for at least, a consultation for potential treatment for our retinal specialists to see if it's something that would benefit these patients. But I think it's really, really important to do that.
I think, Steve, I think the bottom line is, as you said, that many of these patients are with optometrists. So looking for GA, diagnosing GA, and referring GA. And I think the earlier you do it, the better you're going to have outcomes for your patients. So I think optometrists play a key role. And as primary eye care providers, it's important to know what they're looking for. So hopefully this program helped the audience learning about how to diagnose GA and how to refer, and hopefully the risk and benefits of the approved treatment as well as an upcoming treatment.
Fantastic. Thank you so much for being with us tonight, Arshad.